Hi, my name is Danielle Williams, and the title of my research is Undergraduate Nursing Students' Attitudes Towards the Care of Dying Patients. Nursing is a holistic profession. This means that nurses must care for every aspect of the human experience across the continuum of life and death, including physical needs, emotional needs, psychological, and physiologic. Despite this, much of the nursing education is focused on the physiologic and physical aspects of patient care. So there is an increased need for emotional knowledge, especially regarding patient death experiences. This study is necessary for this reason to understand the kind of education our students are receiving. Also, in a study by Ken Anderson and Owens, they found that surprising and unexpected patient death experiences had negative long term effects on students and nurses. So, preparing our students better for these experiences could decrease these impacts dramatically. My research question is: do junior and senior nursing students at an undergraduate baccalaureate program in Northeastern New Jersey report feeling emotionally prepared to care for dying patients? And what are their attitudes? In a research study by Ken Anderson and Owens, the researchers found that surprising and unexpected death experiences were able to be recalled by the nurses many years after the event, and the students and nurses felt very inadequately prepared. Also, they felt helpless and distressed at the time of the event and after the fact, and they experienced feelings such as guilt and regret, particularly because of their lack of preparation. In Peterson and colleagues' study, those students had either none or inadequate death training courses, and what was lacking the most in their education was the emotional aspect of patient death. In Vanderwalth and Detroit study, the students actually felt guilty for experiencing pain and sadness at the time of the patient death. So this again shows the need for an emotional support system and emotional education regarding patient death experiences. Also, the students felt that if they had an opportunity to reflect on their emotions, that they would be able to better manage these experiences in the present and long term. In Zengli and Bloomer's study, they felt that their lack of preparation actually affected the level of care that they were able to provide both to families and patients. And the students felt alone to cope. This again shows the need for emotional support regarding death experiences. In Zuhung and colleagues' study, the nurses felt like they were likely to fear, avoid, and escape dealing with patient death because of their lack of preparation. And in Loftus's study, she found that the students actually experienced physical and psychological experiences of stress, such as rashes and insomnia. This can clearly affect the level of care able to be provided to patients, as well as nursing satisfaction. So, my study was a quantitative correlational research study, which was grounded in Watson's theory of caring. I chose to ground my study in Watson's theory of caring because I am focused more on the psychological and emotional aspects of patient care rather than the physiologic. I obtained IRB approval from William Paterson University in September of 2020. Data collection utilized Qualtrics, and I emailed the survey to students. I utilized the Vermelt's attitude towards care of the dying scale, which was a 30-question Likert style scale, and I included an open-ended supplemental question. I then used ANOVA and regression tests to analyze for any correlations, and the key concepts were the students' attitudes towards death and caring for dying patients, and their demographic data, such as age, UDC level, religious affiliation, previous education on death, and previous experiences with death. So for data analysis, I first graded the tool utilizing the grading system provided by the author of the tool. I then inputted the data into Excel and utilized SPSS software to analyze the data for any correlations. I also looked at the open-ended responses for any themes. For my raw results, the total responses was 60, 21 of which were junior students and 39 of which were senior students. For the Vermelt's attitude towards care of the dying scale, the lowest possible score was 30, which means a negative attitude towards death and dying, and the highest possible was 150, which means a very positive attitude towards death and dying. The mean score amongst my participants was 118, the minimum being 100 and the maximum 145. The total females was 50 and males were only 10. And the age breakdown you can see below, most of my students were 18 to 22 years old. For my data analysis, my one-way ANOVA testing revealed no statistically significant data. This means that the actual death attitude scores had no relationship to the experiences, religion, age, sex, education, and grade level of the students alone. However, my regression testing was statistically significant. This means that a subset of participants that had both previous experience with death and some education on death and dying had a statistically significant relationship. To check their significance, I tested some education without experience with death, and it was not statistically significant. To see the direction of the interaction, I looked at the unstandardized B, which was a negative 6.9. This means that those students that had previous experience with death and some education on death and dying had about 7 points lower on the attitude towards death scale, meaning a more negative attitude towards caring for dying patients and towards death overall. The open-ended themes revealed three prominent themes, the first of which being that the students felt unprepared or inexperienced. The second was that the students felt a desire to be supportive or contribute positively to the death experience. And lastly was that the students had a negative feeling towards death overall, whether it be from fear or their previous experiences. So for a discussion, my hypothesis was proved incorrect. I originally hypothesized that the students would have a generally negative attitude towards death and dying, and they had a generally positive attitude. Also, I predicted that the one-way ANOVA testing would reveal that younger students and lower UDC level students with less experience and education would have more negative attitudes, which was not true. However, the regression testing did yield significant results. So I did find that the previous experience with loss and education on death and dying tended to have more negative attitudes towards caring for dying patients. This does align with the literature in that previous death experiences can have negative long-term effects. Also, it reveals that there could be a potential link to personal experiences with death and professional experiences with death. Also, there could be a resistance towards caring for dying patients based on previous experiences with death or previous experiences with family members that have had similar diagnoses to patients that nurses must care for in the present. For my overall open-ended responses, there was an overall inexperience, but simultaneously a desire to have positive experiences amongst the participants. So this again shows a need for increased preparation, but it could also be a possible limitation because the students could have answered the questions based on how they would have liked to experience patient death rather than how they actually feel. This is also notable to mention because the students that did have experience with death and education on death had more negative scores, and those that weren't inexperienced had more positive scores. Another limitation of my study was the online format, so I was unable to clarify with the students any questions they may have had or any confusion with the study overall. I also had less lower grade level students, which is prominent to note because I did expect that the lower grade level students would have more negative attitudes towards death and dying. Also, it was conducted during the COVID-19 pandemic, so this could have limited the response rate from my students. Future research should study the link between personal and professional death experiences and whether or not there is patient death and diagnosis avoidance based on previous experiences with death and diagnoses amongst family members. Again, there should also be future research about the emotional aspects of patient care and on the preparation of students to care for dying patients. So, the significance to nursing is prominent and many. Nursing students are prepared copiously to deal with the physical aspects of patient care and patient death. However, what about the emotional aspects of patient death? Not being prepared for these patient death experiences could actually lead to physical aspects of stress, like rashes, insomnia, and many other things that could lead to nurse burnout, nurse dissatisfaction with their careers, and nurses leaving the field. Also, patient care could be substandard based on the lack of emotional and psychological support regarding patient care and patient death. There is a need to examine personal experiences with death as well as emotional needs regarding the patient death experiences. Nursing is so much more than caring for a physical body. So, our preparation in preparing nurses to enter the field should also focus on the many aspects of nurses' responsibilities. Also, great nurses are empathetic, compassionate, and supportive, and we must give support and teaching to each and every one of our patients. So we also deserve the same support and teaching back. Thank you so much for listening. Please email me with any questions. Here are my references.